All right, good morning, everybody. I'm Jason Savage from the Cleveland Clinic, and I have the pleasure and honor of co-moderating this next symposium with our current CSRS European president, Carmen Villagret-Lankamp. Hopefully that was not bad. Perfect. It's actually been an absolute pleasure getting to know Carmen over the last couple of days. She's an absolute rock star. So I'm particularly excited about this symposium. First of all, we have four true thought leaders kind of in our field who are all outstanding speakers, and we kind of task them to give talks on stuff that we typically don't really talk about up on the podium. So, all right, now I'd like to call up Sheeraz Qureshi, who's going to give a talk on how can we be conscientious or really cost conscious and still provide optimal outcomes.
Great. Well, thank you very much, Jason, and the rest of the program committee for including me on this. So I was tasked with the topic of thinking about cost and outcomes, and so, I think I want to set sort of a little bit of context. So if we think about what the traditional business model for orthopedic and spine surgeons was, it was to form a relationship with the hospital that you were in the community with, maybe to cover emergency calls, things of that nature. Maybe you got some compensation from the hospital, but then you brought your non-emergent cases to do your procedures there. And spine surgeries, orthopedic surgeries, neurosurgeries were high margin, so hospitals were willing to maintain sort of these extensive inventory of implants and instruments. And we could see, a single orthopedic or neurosurgeon on average would generate a tremendous amount of profit for hospitals. That has significantly changed. So if we think about, what's happening in our industry, 75% of orthopedic surgeons and I would say a significant amount of spine surgeons are now employed. There's a tremendous amount of consolidation amongst the healthcare systems around us, and sort of the purchasing power is getting consolidated through these GPOs. And the way that now spine surgeons are sort of attracted to different places are through these words around value-based payment models and bundled payments, which are often used interchangeably but actually mean slightly different things. And so I thought I would take this time because I think it's important for us to understand what's happening around us. So what's driving the shift? I think that's probably not very complicated. Our reimbursements are declining, our overhead's going up, we've got significant administrative burden, and then there's significant reforms that are extremely costly to us. But again, there's sort of these carrots that are dangled around value-based care and bundled payments. So what are these things? So the hope around value-based care is this emphasis on quality over quantity. And so collecting outcomes is incredibly important. And whether that's through the CSRS registry or our own personal registries, I'm certainly a huge proponent that we should be collecting outcomes. And bundled payments is really a way to achieve value-based care because it tries to take essentially this entire episode of care and says, and what we're being told is by standardizing pathways, really focus on outcomes when we think about clinical decision making. But what really happens in these scenarios is sort of this problem where there's an adverse patient selection, right? You want to cherry pick to maintain your performance. The financial incentives have shifted, and really there's these procedure-driven challenges. So as surgeons, you're sort of forced to adapt around sort of patient management and away from procedure focus. And bundled payments are not necessarily all good either for anybody because, again, it can actually lead to a disparity in access because why would you take care of sicker patients if you're going to have worse outcomes and then get paid less for that? And, of course, there's a significant increase in burden. So hopefully that's bummed everybody out enough as we've talked about this topic. But this is even better because while, we all face these challenges in our professional fees, and you could see here that our reimbursements over the 20 years have declined by nearly a third, inpatient fees and especially outpatient fees continue to rise or at least not face the same challenges. And some of this is starting to change a little bit. But that is the context that we're dealing with, right? So how have we as a industry tried to figure this out? It's trying to figure out how we capture more of the pie. right? And that's, I think, when we think about the role of ancillary services and how to control the pie through whether that's physical therapy, imaging, ambulatory surgery centers, that's the areas where perhaps an additional revenue stream can offset some decline in professional reimbursement. However, we talked about nearly 80% of surgeons now being hospital employed, you lose that ability, right? So this is really a classic catch-22. So what is the value equation for surgeons, right? I mean, hopefully that, that context will allow for some conversation. But if we think about what value is, it's quality of the care that we're providing, the total cost of that care, which is the denominator in the equation, over a certain period of time, and then the quality portion of it is really measured as the outcomes that we're achieving, are we doing it safely? And then obviously we're in the service industry because our quality is not only judged by our outcomes, but are our patients happy in how they got to that point, right? So we have to think about that factor as well. So how does this all tie together in cervical spine surgery? So here's, I put up 3 trends. Trend number 1 is, I think good news. Cervical spine surgery continues to have an increasing prevalence, and by 2040, there's going to be an estimated 170,000 anterior cervical discectomy infusions, 35,000 posterior cervical fusions, and that's just what's happening at inpatient hospitals. So there's plenty of work to do. Also, motion-sparing surgery, so thinking about disc arthroplasty, laminoplasty, every surgery across the board that we perform in cervical spine is increasing. And that's not just because we're doing more, but the patients are getting older, and there is an increasing need for these degenerative types of procedures. The other trend is that cervical spine surgeries are becoming more complex. So if we think about the fact that patients are getting older, 50% of anterior surgeries are projected to be in patients 75 years old or greater, and almost 75% of the increase in posterior cervical surgeries is going to be in that age group in the elderly patients. So we are taking on more risk. So if we think back to these value-based care and bundled payments, you have to think about, are we setting ourselves up for success or are we setting ourselves up for a disaster? As the operations become more efficacious, we're willing to take on more risk. The average comorbidity burden across all of these cases has also increased. There's a concomitant increase in circumferential cervical spine surgery, and when we think about cost drivers, that is going to become important. And then the last trend that we're seeing is this move towards outpatient surgery. And certainly there's a safety in doing surgeries on an outpatient basis, whether it's at 1, 2, or multiple levels. But again, you have to think back to who's taking the risk. The patient is certainly taking the risk. The surgeon is taking the risk. But that can be a significant thing that we want to think about. At this point in time, only 50% of surgeons, this was a survey study that we did several years ago. Even today, though, only 50% of surgeons say that they would perform a 1-level ACDF at an ambulatory surgery center if there wasn't the ability to keep a patient overnight, for obvious reasons. And most ambulatory cervical surgeries are being done in an outpatient hospital setting, not an ASC. So if we think about where are we capturing that pie or where the opportunity is, it's not necessarily putting us in a good position if a lot of us in this room would say, I'm not even comfortable doing the surgery because of certain risk factors. So again, just getting back to the trends, cervical spine surgery is becoming more common. Our patients are becoming more complex, and there is this trend to almost, whether it's our decision or whether it's being forced, things are moving to an outpatient. And at the end of the day, whether we're going to move it to an outpatient or not, we're going to be paid like they're being done at an outpatient. And that's really what the issue is. So what are the cost drivers? So implants continue to be the main cost drivers. We could see here that posterior circumferential fusion has the highest cost. Costs are significantly varied by region. This was a study that we had published many years ago that just showed that, there is a cost difference here. Anterior surgery for myelopathy, at least in 2014, with the studies that were available, seemed to be more cost effective. Posterior cervical foraminotomy was the most cost-effective procedure for obvious reasons in single-level radiculopathy. So this is where the cost is shifting, and we need to think about that. But if we think about how we're actually treating patients, posterior cervical foraminotomy for single-level cervical radiculopathy is actually decreasing in its utilization. So perhaps we're not actually, as surgeons, thinking about cost, and we should. Similar data here for laminoplasty versus laminectomy and fusion, as well as for ACDF and arthroplasty. Again, just kind of emphasizing that implant cost is driving a significant portion of the cost, and we probably need to partner with our industry partners to figure this out. Biologics are a significant part of the cost equation, and we can see here that whether it's infuse, whether it's allograft material, I think having some standardization around not only cost, but also what works and what doesn't to figure out the cost equation is going to become really important. Neuromonitoring, how many people in this room use neuromonitoring as standard for cervical spine surgery? Yeah, it's a pretty significant number. I do also. But it is a cost driver and increasingly not being paid. And so again, we have to think about who's driving these decisions around safety, both in where these surgeries are being done, what we're using, and what the cost drivers are. I know I'm actually over time. So just really quickly, last couple of slides, revisions are the biggest driver of cost, generally about $20,000 a year, which I think is probably an underestimate. In summary, the trends are more cervical spine surgery, more complex patients. We're probably being forced to at least get reimbursed for these procedures as if they're being done as an outpatient. Cost drivers are the implants. Try not to do revision surgery if you could avoid it. And inpatient surgery is a cost driver. So I'll stop there because I'm way over time, but thank you very much and look forward to the discussion.
We have about 13 minutes for questions and discussion. While the discussion is happening, I just want to put a quick plug in. We have 3 research projects going on that are survey-based. So if you can take the time to kind of scan these QR codes, if you don't mind, and kind of fill these surveys out, it's obviously critical to our mission as a research society. So, I'll start maybe with questions, since I don't see anyone at the microphone yet. For Todd. Todd, I absolutely loved your talk. I think one of the biggest kind of privileges that we have as surgeons is to educate, right? I really do believe that. I love how you kind of started with saying we not only have to teach the how, but the why, right? I think a lot of us kind of tell our trainees that the surgery is the easy part, it's everything else that's really hard, right? But my question to you is, what are your thoughts in terms of how to homogenize kind of surgical training? Because I think we all see residents come into our fellowships and they come in at very, very variable technical kind of abilities. So, and I guess I'm kind of trying to say is, do you think we should go towards a spine track and training program, or how do we kind of homogenize that training?
Yeah, so I've long thought that we'd be better served. I'd be one of those people that would vote for kind of a specific spine training. Everybody get a basics of a few years and then track into where you have like a 3-year spine training, and it's both neurosurgical and orthopedics. And I spoke at this at the joint section, and honestly, orthopedics could tolerate it economically. I'm not sure neurosurgery could tolerate it economically, because in neurosurgery departments, a lot of the juice comes from the spine surgeons. And somebody can get up and correct me if I'm wrong, but I think that's true. And I think that's been an issue in terms of hard to homogenize those two groups of people. And we'd be better served as surgeons and to our patients with that training. In terms of like the equalization, people are just better. They're better golfers, they're better pitchers, they're better batters, and there's a natural difference, as we all know. If we've trained hundreds and hundreds of people, people come at different levels. But there are ways to get people to very competent levels, and it's usually you have to teach them the right thing. Indications is the first thing, not necessarily technical skills, because if you pick the right indications, the right surgeries, and choose what surgeries to do and stay in your lane, your patients are going to generally do very well. That's number one. Number two, this simulation thing can get people who are maybe a little behind. You get them into the simulation lab, and they can practice whatever it is they need. Then there's a third group of people that, I don't want to say they're handicapped, but they just don't have a vision of, they don't know depth perception. I will say they might know right and left, but they don't know depth perception. And I've actually had to have the difficult conversation with a few residents saying, and they didn't always listen to me, saying, I don't think you should go into spine surgery. Not to belittle our other orthopedic specialties, but I'm like, go into something where you're not going to kill or paralyze somebody, because you're, I don't want to say dangerous, but I don't think you have the skills to do it. That's a very small subgroup, but that's just my thoughts on how to equalize it.
Yeah, I agree, and that's kind of sometimes the hard part of being a good mentor in that situation is kind of giving honest, right, critical feedback. So that's great. Microphone on the left here.
Hi, my name is Amin Bargi. I'm a PGY5 ortho resident. Dr. Albert, are there any discussions in some of the higher echelons of spine surgery of creating a spine-specific residency, just like I6 cardiac, I6 vascular? Second question from Dr. Borodke's talk, but really for all 6 of you. Do any of you have any experience with professional executive coaching and how that's different from mentorship? If so, can you speak a little bit about when you started that, what that journey was like, and whether it was transformative for you or not? Thank you.
Yeah, I could start with try and do both. I'll let Daryl talk about the coaching, but there had been talks. It died away. There was maybe a decade ago, there was a talk about it. But for the reasons I said, I think organized medicine, organized orthopedics, and organized neurosurgery pushed against it. What needs to happen is some forerunner needs to be an exemplar and try it in their residency program, get approval from an ACGME. And actually, Hanjo Kim at our place had talked about doing it. We never got it done. But somebody has to try it and say, you're going to start 2 years, you're going to do this basic training, the board has to approve it, you're going to get these 2 years, and then we're going to put you in a 3-year spine track. Somebody has to give the example and train a few people, I think, for it to happen.
Yeah, real quick, it's a great question on executive training, essentially, executive mentor or executive coaching. It's of great value, I would say, just as an outset. At our place, the University of Utah, all of our chairs go through at least a year of with a coach. Usually they're from outside the facility, so they're remote, as was mine. And the values specifically for me, I'd done a lot of leadership work prior to that, so it wasn't new to me in any way, but there remained significant value having somebody who's sort of trained in the world of business leadership, because this person wasn't even in medicine per se, to really, and also really separate from my day-to-day issues and unaware of the people that I need to work with and on. And that value really comes in sort of bouncing your own ideas, fears, concerns, processes to somebody who really has heard it all, essentially. Kind of like when a patient comes to you for a consult, very similar, except you build a relationship with that person who can then kind of see your style, see your questions, see where you may actually benefit from that coaching. And I think it's incredibly valuable.
I will add one thing, Daryl, if I can. I did start a business, like when I stopped being a chair of doing this. I wouldn't call it coaching. I called it professional mentoring, where I've had about 3 people who were chairs or division chiefs. We'd meet, and I did it. I said, I'm going to be like a concierge doctor to you. You call me when you need me. Their institutions paid a little set amount, and I'd meet with them once every week or once every 2 weeks. I think it could be useful for somebody who's just been ahead of you. It's worth it. Sorry, I didn't mean to interrupt.
No, yeah, I think it's a great question. I mean, I don't think any of us are really born, right, leaders or mentors, and I think it's something that we can improve at over time with coaching and learning from people that are on this stage. So, microphone on the right.
I want to thank you all very much. Steve Lockheed from UVA. Dr. Qureshi, great talk. As somebody who's just starting out, some of the statistics you presented are quite daunting. I think as surgeons and as leaders over the last 20 years, many people in this room have been fantastic at adapting to the changes. But if you look at the data, the number of health executives have grown exponentially, and the number of doctors and surgeons has remained relatively stable. Yet the only way the healthcare system or hospitals generate any revenue is if we see a patient, order a test, or do a procedure. So I guess my question is there a role for us to be better advocates or be more organized in fighting back against some of these changes to preserve what we do for patients in the next 20 to 30 years? And Thank you.
Yeah. Thanks, Steve. Thanks for the question. I think, number one, it's really important to collect your outcomes and know how you're doing, because we're part of a larger pie, and I think it's really important for the AMA and at every level to see the importance and really the value that spine surgery delivers to patients. Unfortunately, oftentimes in the news and other things, like, it's always the bad outcomes, but not the millions of patients that are helped by spine surgery. So I think it's just a plug that everybody should be collecting outcomes on their patients, whether it's through the registry here or through others. And I think it's just important to have a voice, like know what's going on and have a voice, as opposed to just saying, well, this is what it is, we just gotta, I don't have any other options. There are other options out there. I think the most concerning statistic to me is that, the number of surgeons now that are moving to employment models, whether that's with private equity groups or hospital employed. And I think it's really important that we figure out, how to provide better options.
I'll just add one. I think that's a great question also. And just to add to what's been said, if you look at the rise of all of these healthcare executives and so forth, it is a really daunting situation. But I do think they have helped accomplish two things. One is they've really brought focus to patient quality and safety. And they've also helped healthcare systems move towards real standardization. And by standardization, I mean not just standardizing surgical procedures, but standardizing access to healthcare systems, standardizing the approach to spine care. And I think that if we get involved in that, and we get involved in what's required to improve the quality and safety, and what's required to really standardize care in a way that's really beneficial to our patients, then we'll be an important part of that process, and we'll be able to affect what the ultimate outcomes are.
Is it okay if I just ask one quick follow-up to that comment? I agree completely, and thank you. But I just my follow-up question to that is, we have standardization. And the problem is, though, that we then standardize, and I think the system and administrators sometimes look at everybody the same way. And they say, well, the care, and that gets to the point of the cherry picking, right? The care in the community is the same as the care in the academic center. The outcomes should be the same. The reimbursement should be the same. And the standards of level of care and how patients do in complications should be the same. And at the same time, when you standardize care, sometimes the easiest, like this recent cut in reimbursement, 2.9%, the easiest way to control costs is just say, well, we're going to cut how much we pay for this procedure. We're going to cut physician reimbursement. So while standardization is great, and I think as we were able to deliver better quality, better safety, we also have to have a voice in advocating to maintain reimbursement for what we do, because what we do is unique and important, and we deliver a lot of value for the healthcare system and society as a consequence.
Related to that, I think, again, where we as spine surgeons can really bring data forward that really emphasize the value of what we do. It's not just in the hospital where we can work towards standardizing, what instrumentation is used and bringing those costs down. I think ultimately the real value of what we do is we get people back to work and we get people back to productivity. And I think that ability for us to articulate that and to have the data around that is going to help us advocate for improving the reimbursement for what we do. Because if you look at the entire societal perspective on cost, spine surgery is incredibly cost effective. But it has to be looked at outside of just the hospital episode. It has to be looked at this in terms of return to work and productivity.
Steve, I'll just add one more thing. The fact that hospitals are willing to employ spine surgeons on an increasingly frequent basis should clue you in that, that you're probably worth more than the reimbursement you're getting.
Yep. Thank you.
All right, I'm going to extend this discussion for 5 minutes. I think we'll have time for 2 questions. Go ahead.
Thanks so much, Justin Tortolani from Baltimore. Thanks to the panel. Thanks for the idea to put this together. I think it's a fantastic topic. And my question really deals with technical skill acquisition. And the question is, and I struggle with this myself, when are we good enough? Is there a line where we are then good enough, or should we always be striving to be better? And one of the fallacies that I think in surgery is that when we finish our fellowship that we're somehow good enough. When you look at chess or music or professional sports, we're continually getting coached and we're watching video and we have deliberate practice that goes throughout our entire career, and it's not just knowledge acquisition. So the question I have for the panel is just this philosophical one, really, is are we ever good enough? And how can we make sure that we're continually to be better over the entirety of our careers? Thank you.
Yeah, Todd, you want to?
Yeah, I'll take a shot at that. Great question, and I think the answer is no. You're never good enough if you want to be the best. Vince Lombardi would say, gentlemen, we are going to go out and seek perfection, and we're going to seek it and seek it and seek it. Though we may never achieve it, in seeking it, we will achieve excellence. And let me tell you, I've been doing this now 30 years, and every day something happens, I go, whoa, I never thought that could happen. I never saw that before. So, and if I just thought I knew everything, I can't learn everything. I can't learn anything new. And we've had some fellows who thought they knew everything as coming in as a fellowship and into their fellowship. They didn't learn so quickly. So you should think you don't know everything and be open to learn, and you keep getting better. That's my opinion.
Yeah, I completely agree with that, Todd. I think it's a great question, and I think we do have to do a better job somehow of kind of evaluating that process throughout our careers. And I'm not even sure if it's the technical aspect of things that we kind of have to monitor as closely. It's a lot of the indications, and kind of we all see some stuff that's being done, and we kind of scratch our heads and say, huh, that's weird. They probably didn't learn that in their fellowship, right? So, yeah, last question, Brad.
Yeah, Brad Courier, great session. Thank you all so much. Question for Daryl. Daryl, when we think about mentorship, we're often thinking about the trainee relationship. You've mentioned executive coaching, which is wonderful, but not everyone in the audience has desire to be a chairman. But when is mentorship, when are you too old to have a mentor? And, and how do you establish that relationship? If you're a young surgeon or anyone needing mentorship, how do you find a mentor?
Yeah, maybe I'll tackle the second question first, 'cause I think it's really important for us as leaders in our local markets, leaders in our profession, all of us, that we take on this idea of a mentor-mentee relationship. And it does not have to be with somebody younger or inexperienced or in training. It's really about developing a relationship with someone in a deeper way than superficially over coffee, that can lead to challenging either the thoughts that you have at any age. So I don't think there's an age after which you no longer can have be a mentee. Because there's always going to be something that you're frustrated or confronting that somebody else has done, seen, been through, or can provide perspective on. And so that's really the value, I think, of mentorship. And this societies in general, but this one in particular, because it's really built for that in its history, as you can see from those early talks and Harry's presidential address. This society is built for that. So you don't have to be in contact with your program director or your chair or your people you did residency with in the past. You can also find that in relationships right next to you right now. So I guess that's how I'd answer it.
May I add something to that? Like in continuation of what we heard yesterday, I think that it is also important for this young person is that they see that the elderly in the field of where you're working also seek for feedback. And you not only have to seek for feedback with your peers, but it's also, I think, important that while you guide your mentee, that during that process, that your role changes, also asking feedback from that mentee, and hopefully that makes it easier for that younger person to also ask you to, can you be my mentor, or can I approach you for different questions than how to put this screw here, but also for questions that really matter.
Thank you very much.
I'm sorry we don't have time for the final question, but we do have to wrap it up. If you want to come up to the front at the end, we'll be up here because we are at time. I just want to thank the 4 speakers and my esteemed colleague and co-moderator for an outstanding session. We are going to break, and then we're going to start the next session at 10:50. Thank you.